Good morning, good afternoon, or good evening. This is Biology 205 at Illinois Central College, and this is Anatomy and Physiology 1. Today we're going to be talking about the integumentary system, which is skin. I think you're going to love it. Let's go.
Learning outcomes for today's lecture include the following: to list the general functions of the integumentary system, describe the parts of the integumentary system. This includes the epidermis, the dermis, and accessory structures, as well as the subcutaneous layer of connective tissue that is subjacent to it. Describe the characteristics of the epidermis, to know the function and the cells of the epidermis. So this includes keratinocytes, melanocytes, and Langerhans cells. You'll also be able to explain the 5 layers of the epidermis and describe their functions and characteristics. This includes the strata germinativum, spinosum, granulosum, lucidum, and corneum. Also, you'll be able to describe the process of keratinization, compare insensible and sensible perspiration, and relate that to dehydration and hydration to the epidermal layer. Describe the causes of different colors of skin. That includes things like keratin and the role of melanin and melanocytes and blood flow. Also, you'll be able to discuss the response of melanocytes in our skin to ultraviolet radiation. You'll connect ultraviolet radiation, vitamin D3, and calcitriol, as well as their functions in the body. You'll be able to describe the structure, characteristics, and function of the dermis and the dermal layers of the papillary and reticular layers. As well, you'll be able to look at explaining the dynamics of the following sensory receptors: Merkel's, Meissner's corpuscles, Ruffini, and Pacinian corpuscles. You'll also be able to describe the structure and function of the subcutaneous tissue, list the function of the accessory structures. This includes the hair, sebaceous glands, and nails. And lastly, you'll be able to list the steps of repair to localized injuries.
Let's get into discussing the integumentary system. This is effectively skin, and so it's important to know that when we talk about the integumentary system, we are talking about the cutaneous membrane, which is just the epidermis and the dermis. There is the hypodermis, which sounds like it should be part of the skin because it has dermis in its name, but keep in mind it is hypo, meaning below. So it's below the dermis, and it is loose connective tissue. There are also accessory structures that are part of the integumentary system, and those primarily include hair, hair follicles, exocrine glands, and nails. Now, the skin is the most important barrier to the exterior world because it is the largest organ in our body. So we're going to go into some detail and discuss all of these different accessory structures and the integument itself. Figure 5-1 in your text gives you a really nice look at a cross-section of skin. And so the cutaneous membrane is going to be comprised of the epidermis and the dermis. So if you look on the left, you can see how those two structures are demarcated, where they start and where they stop. So you'll notice that the epidermis stops right where that purple wavy line is at the bottom of the epidermis. That is the basement membrane, and we'll talk about that coming up. Beneath the epidermis, we have the dermis, which is divided into 2 layers, one that is more superficial and one that is more deep. So when we're describing skin, we would always discuss superficial and deep. We wouldn't say superior and inferior. So in this case, the papillary layer is shown to be at the top of the image, and the reticular layer is lower in the dermis. And then as you go down to the very bottom on the left, you'll see that there's a component that is not included in the heading cutaneous membrane, and that is the subcutaneous layer, because it is beneath the cutaneous membrane. So down in the subcutaneous layer, you're going to see those yellow blobs. Those are all fat cells or adipocytes. There are also a bunch of blood vessels that you see running along the bottom, and they're just slightly above where the adipose tissue is. And those are subpapillary plexi, or a plexus singular, and they're basically comprised of innervation and vascularity. Now, if we go over to the right, you're going to see a whole list of accessory structures because there are a lot. So first off, there's a hair shaft at the very top, and the hair shaft is the part of the hair that actually sticks up that we would just call hair. And then there are pores, and those are pores of sweat glands that allow perspiration to occur. Moving down lower than that, we have tactile corpuscles, and you can see those have a very distinct shape. They kind of look like a spoon. Similarly, by the way, a little bit further down, you'll see there's a large structure that looks like that, and it's called a lamellar corpuscle. Anyway, these corpuscles are both just basically sensory nerve endings that are going to sense a whole variety of different things, ranging from pressure to vibration, pain, temperature, etc., etc. So then moving further down on the list on the right, we have sebaceous glands, and you'll note that the sebaceous gland is just off to the side of an associated hair follicle. So it doesn't operate independently. It operates in conjunction with that hair and releases its product around the hair to keep it lubricated. Beneath that, we have the erector pili muscle, and the erector pili muscle is important because what it does is it stands up the hair. So whenever you're cold and the hair on your arm stands up, you can thank your erector pili muscles for doing it for you. We also have sweat gland ducts that you can see, and those are coming up through the pores of the sweat gland ducts. There are nerve fibers further down below, and again, sweat glands. When you get a little bit further down into the subcutaneous tissue, again, you can see that we have arteries and veins in the cutaneous plexus as well. The integumentary system has a lot of functions, and the first thing we probably think about is protection. So our skin, of course, is the outer barrier of our body, so it protects us against a lot of things. First off, ultraviolet radiation, also abrasions or any type of injury. It protects us against infection so that infectious organisms and microorganisms in general can't just gain access to the interior of our body. And it protects us against excess fluid loss. This is very important when we discuss burns, and we'll discuss that at the end of this chapter. It's also important for maintaining an appropriate amount of excretion of salts and water and waste by glands. So the glands in the integumentary system are going to be releasing their products to the skin, whether either through a hair shaft follicle or through an actual pore of a sweat gland duct. It's also important for thermal regulation. So we perspire to maintain a normal temperature. And so the skin helps us to cool down, but it also helps to generate heat by standing up all those little hairs via those erector pili muscles. The skin also is important in producing melanin, and melanin has a protective effect against ultraviolet radiation, which we'll also discuss later. There's also vitamin D production, which occurs in the skin, which is fascinating because most vitamins are actually only things that we can ingest through our diet, but we can actually synthesize vitamin D through our skin via sunlight. We'll talk about that also. There's also lipid storage in the adipocytes and the subcutaneous tissue, and sensation. We can sense touch and pressure, pain, and vibration, and temperature, all through these different sensory nerve endings that are embedded throughout our skin, throughout our body. And then lastly, the immune response is coordinated via the skin to respond to a lot of different types of pathogens and also skin malignancies. So for today's lecture, we're going to use the same outline format that we've used in the previous lectures, following along the order of the textbook. The first 5 sections are rather lengthy and in detail, but after that, the next 5 move along pretty quickly. So let's start off with 5-1, the protective epidermis. The epidermis is our most superficial level of our entire integumentary system. It is what you touch when you feel your skin, and it is composed of stratified squamous epithelium. Stratified squamous epithelium, you might recall from our previous lecture, is important for resisting any type of abrasion or friction or injury. All of those layers of cells are there to create a protective effect for everything beneath it. So our epidermis is water resistant, although not waterproof, but it does provide a barrier of moisture between the outside world and our bodies. Now our cells are going to rise to the surface from the bottom at the basement membrane over about 45 to 50 days in most cases. And in some places there's a higher turnover, but for the most part we can just use 45 to 50 days for a good general estimate. So if you look at the image on the right, you're going to notice that there are these sort of extensions sticking down into the very most pale part down at the bottom. So those extensions, if you look at the very bottom of them, you'll see they're packed with these dense, dark cells that have dense nuclei in them. And that is the lowest level of the epidermis. That is where the cells start from. They grow from there, and then they rise up. And as you can see, as they rise up to the top of the image, you'll see that there are no nuclei at the top. Because by the time you get to the top, those cells are all actually dead. They're held together, but they are actually completely dead, non-nucleated, and they're filled with keratin, which is important for maintaining a nice water-resistant barrier to the outer world. The epidermis is avascular, meaning that there are no blood vessels in the epidermis. So what that means is that all of those cells obtain all of the nutrients that they need from dermal capillaries diffusing into the area. When you're trying to learn the 5 different layers of the epidermis, which you'll see listed on the right, the stratum corneum, the stratum lucidum, the stratum granulosum, the stratum spinosum, and the stratum basale, which is also known as the stratum germinativum, you can look at the little mnemonic down at the bottom here. Come, let's get sunburned. And if you use the first letter of each of those words, it will give you the order from most superficial to most deep of each of these layers. The epidermis is composed of a number of different cells, but keratinocytes really comprise the vast majority. So keratinocytes, hence the name, are cells that produce keratin. And that keratin protein is going to have an important function in creating a water-resistant barrier in our skin. Other cells that are present include melanocytes. So you'll see in the image to the right, which is figure 5-8 in your text, down at the bottom, the schematic shows you a large, almost octopus-like shaped melanocyte. And the melanocyte is producing melanin pigment to the surrounding keratinocytes and releasing it into vesicles called melanosomes. And so this is going to be an important part of protecting us against ultraviolet radiation. There are also Merkel cells, which are tactile and sensory nerve endings that are present. And there are also Langerhans cells, which are part of the immune system, and they work as macrophages to help clean up any debris or infectious organisms, things like that. If you recall from a couple slides ago when I showed you the come, let's get sunburned, 5 layers of the epidermis, well, in thick skin, we have all 5 of those strata. But in thin skin, we're actually only going to have 4. So in thin skin, we are lacking the stratum lucidum, which is the clear layer. And in thin skin, those individual strata are actually thinner than in thick skin. So you can find thick skin really only in a couple places, on the palms of our hands and the soles of our feet, because these places have a lot of friction, a lot of contact with the world, and they need a lot of protection. Let's look at the different strata of the epidermis. So let's start at the very bottom, because that's where the cells start and they grow up, and then eventually they're going to die and desquamate or fall off, basically. So at the very bottom, you can look at the image on the left, and you'll see that the darkest pink component has a wavy bottom to it, and that is the epidermal ridge. And what you're looking at the very bottom of that dark component that's wavy are a lot of those densely packed cells with big nuclei. And they have big nuclei because they have a lot of activity. Those are the cells that are turning over and creating new keratinocytes regularly that will keep continuing to grow, mature, rise up through these levels, and eventually slough off. So we start off at the very bottom with the stratum basale or the stratum germinativum. So you can think of this as the basal layer, so that makes sense. Or also, if you're into gardening, you germinate seeds, and that's exactly what's happening here. The cells at the very bottom are germinating, basically. They are starting to grow new cells. So the stratum germinativum, or basale, is the deepest possible layer of the epidermis, and it attaches to what is called the basement membrane. And the basement membrane is what separates the epidermis from the dermis. So let's move up one more layer. We have the stratum spinosum, which is known as the spiny layer. And it's spiny because if you look at the cells under a microscope, they have little tiny extensions off the edges of them. And so they do kind of look like they have spines on them. Now, you can't appreciate that when you look at an image at this level of magnification, but you can if you get a little bit more zoomed in. Going up one more layer yet, we have the stratum granulosum, and you'll see that that's not terribly large. And so this is a site where we start producing keratin in our cells, and we have keratin fibers that are developing, and those keratin fibers are going to be very important in helping to hold together the cells at the surface once those cells die. And then one step further beyond that, we have the stratum lucidum. And the stratum lucidum is only present in thick skin on the soles of your feet and the palms of your hand. You won't see it in any of the other skin on the rest of your body. And so it is kind of a clear layer. It's just an additional layer of protection. And then finally, at the very top, we're up to the stratum corneum, or the corny layer. And it is basically a lot of keratinocytes that are dead, but they are all locked in together with keratin fibers, and this creates a water-resistant but not waterproof barrier. Just to help you get used to looking at this and feeling comfortable with it, here's another slide from a text from several years ago, just so you can kind of get used to identifying these different layers. So again, if you look at the bottom where the orange meets the pink, that would be our basement membrane, and also the stratum germinativum or stratum basale starts there. That's where cells begin to grow and then migrate up to the superficial aspect. The next step up is the stratum spinosum, the spiny layer. Going up one more, we have the stratum granulosum, or granular layer. And you can see there are actually granules, little tiny, fine, looks like gritty little pieces in those cells. So that helps differentiate the stratum granulosum from the spinosum below it and the lucidum above it. And again, the lucidum is only going to be identified in thick skin, and it is kind of a clear, glassy looking layer. And then finally at the top, we have the stratum corneum, or the corny layer, and then the very surface at the top of the screen here. Now let's look at the layers of the epidermis one at a time, and we'll start at the deepest and work our way up just like the way cells grow. So with the stratum basale or germinativum, we have a 1 to 2 layer thick basal layer, and in this basal layer we have the basal or germinative stem cells, which dominate the entire area. And they have to, because this is their job. Their job is to basically produce a lot of keratinocytes to rise up, eventually die, lose their nucleus, and then slough off. So down at this layer, you're going to find melanocytes present that produce melanin, and you're going to see epidermal ridges that are going to be basically building off of the pattern of the dermal papilla beneath it. So the dermal papilla are those pale pink extensions that look like they're sticking up into where the stratum basale is, or you could say that the stratum basale is poking down into the dermal papilla. But either way, that's the basis of our fingerprints. The stratum basale also secretes basement lamina, which creates the basement membrane. And the basement membrane is what differentiates the epidermis from the dermis. And this is important in differentiating just different types of cancers in terms of how deeply they've invaded. And then cancer treatment will be based upon how much it's invaded. There are also tactile Merkel discs present, and these are only going to be found in non-hair-bearing skin. Next, let's move more superficially one level. So the stratum spinosum, or the spiny layer, is what is one step more superficial than the stratum basale, or the stratum germinativum. These cells are about 8 to 10 layers thick, and they're held together by desmosomes. There is a little bit of cell division that occurs in this layer, but not a whole lot. The vast majority of the cell division is occurring at the stratum basale, or the stratum germinativum, where the cells germinate or grow. There are also Langerhans cells present, which are dendritic cells, and these stimulate defense against microorganisms, the outer environment, or also different types of skin cancers as well. Moving up superficially one more layer, we have the stratum granulosum, or the granular layer. You can see that the cells in this area do have granules in them that are different from the cells both above and below. This is only about 3 to 5 layers thick, and there's less cell division here than in the stratum spinosum, and even less than compared to the stratum basale or germinativum. Keratohyalin is produced here though, and this is very important because keratohyalin is going to dehydrate cells, and as they dehydrate, they're going to start to die. The organelles inside are going to disintegrate, but there's going to be keratin fibers that cross-link all of these dead cells together to create a firm barrier. And if you're wondering, like, well, how thick is this, and how strong is it? Well, keep in mind, it doesn't come off. It's attached very firmly. So keratohyalin is what is holding our skin down. Moving superficially one additional level is the stratum lucidum, or the clear layer. So think of the term lucid. It means that somebody is clear, they're thinking clearly. So this is actually a clear area of tissue where we don't have very much density in the cells. And this is the level that is only found in thick skin, again on the palms of our hands and the soles of our feet. So it's kind of a transparent, glassy, thin layer, and the thickness of it is going to be contingent upon the amount of use in the area. So what this means is if you play guitar all the time, for example, and you get calluses on the tips of your fingers, you're going to find thicker stratum lucidum in that location. Finally, we reach the top, the very most superficial component of the epidermis, the stratum corneum, or the corny layer. And the corny layer is hard because these cells are cornified or keratinized. And it'll comprise about 15 to 30 layers of all of these dead cells that are all held together, connected via desmosomes. But they're also held together by that keratohyalin. So there is soft and hard keratin, of course. We would imagine that soft keratin would be in our skin and hard keratin would be like, hair and nails, right? So these are things that you'll find depending on where you are in the body. Because the stratum corneum is water resistant but not waterproof, fat-soluble substances can diffuse through this layer to gain access to any subjacent tissue. And again, keep in mind the stratum corneum is a water-resistant layer and not a waterproof one. Time for what I like to call fun facts about the stratum corneum. So if you look at your fingertips, you're going to notice your fingerprints, and these are unique to you. And as a matter of fact, even identical twins are going to have different fingerprints for a couple different reasons. So our fingerprints are mirroring the patterns of the dermal papilla. So that plays one role. Genetics also plays another, but then a third factor, which is why identical twins are going to have different patterns, is because the fluid, the amniotic fluid specifically in utero, is going to have a factor in how our bodies grow. So if we're pressed up against the wall at a certain point, or we bend to the right instead of the left because our mother rolls over, things like this will actually play a role in helping our fingerprints to form slightly different patterns. We also have both sensible and insensible perspiration that evaporates off of the stratum corneum. And so sensible perspiration is essentially when you sweat and you know it. Okay, you sense it. Insensible perspiration is what we do all day long and don't ever think about it. So if you never go to the gym and you don't work out, you still are going to be secreting fluid insensibly. So that is the insensible perspiration. When people have burns, that's going to be basically damaging the ability of our stratum corneum to regulate fluid loss. So if you have a burn, fluid can leak out very easily and cause massive dehydration. Blisters have the same risk, except blisters are enclosed. So in a blister, the fluid ends up localizing right underneath the surface of the stratum corneum. Another fun fact. You may have thought that when you get into the bathtub for a long time and your fingers swell and you get these pruny, raisin-like hands, that it's because they've swelled up and absorbed more water. But in fact, that's not it at all. We have the exact opposite situation happening, even though it very much appears that you're swollen. We actually have vasoconstriction. So the blood vessels in our skin are constricting, and in doing so, the subjacent tissue shrinks and gives the appearance of swelling. And then one last fun fact. Epidermal growth factor is something that's found in salivary glands and duodenal glands, but it's incredibly important for stimulating epidermal growth in tissue culture. So when we try to grow skin to graft for burns and things like that, epidermal growth factor plays an incredible role in speeding up the development of the stratum corneum and epidermis in general. Pop quiz time. The most abundant type of cells in the epidermis are A. keratinocytes, B. melanocytes, C. erythrocytes, or D. chondrocytes. Well, starting from the bottom and working up is D. chondrocytes, cartilage. We don't have cartilage in the epidermis, so you can rule that out. C. erythrocytes, that's red blood cells, so no. B. melanocytes, well, we're getting warmer. There are melanocytes that are present in the epidermis, but they are not the most abundant type. Keratinocytes, cells that produce keratin, are the most abundant type of cell in the epidermis. So the answer is A. In which epidermal layer does the majority of mitosis occur? A. The stratum corneum, B. The stratum lucidum, C. The stratum granulosum, D. The stratum spinosum, or E. The stratum basale. Well, we talked about this earlier about how everything starts at the most deep level and works its way up. So even if you didn't know anything, you'd probably guess the basal layer is probably the bottom. So yes, in fact, E is the correct answer. And you'll also notice that I've organized everything here from the most superficial to the most deep. Don't count on that during exams. Questions can be randomized, answers can be randomized as well, so don't expect that to tip you off. The types of cells responsible for skin pigmentation in the epidermis are A. Keratinocytes, B. Melanocytes, C. Erythrocytes, D. Chondrocytes, or E. Langerhans cells. So you might think, oh, well, that Langerhans cells option is new, but no, that's not it. We've already ruled out chondrocytes. It's not cartilage. It's not erythrocytes, red blood cells. Melanocytes produce melanin, so the answer is B, melanocytes. Let's move on to section 5-2, the supportive dermis. So one key point before we go any further is to note that the tissue in the dermis is not epithelial. The epidermis is epithelial, but the dermis is not at all. The dermis is the deeper of the two layers of the integumentary system, because keep in mind, the hypodermis is not part of the integumentary system. There's a little bit of adipose tissue, but not a lot. Macrophages are also present, and we can divide the dermis into two layers, the reticular layer or the papillary layer. So the reticular layer is deep, and it's comprised of dense, irregular, collagenous connective tissue. Superficial to that is the papillary layer, and it's composed of areolar tissue, which is much more loose. A clinical correlation for you is dermatitis. So dermatitis can be very nonspecific and sometimes even hard to diagnose to figure out what the actual causative agent would be. So dermatitis is a very broad term that could apply to anything from poison ivy to any type of other allergic reaction. It's generally just inflammation of the skin. And so primarily the papillary layer of the dermis is what's affected. The papillary layer is the most superficial of the two layers of the dermis. And so the papillary layer, as you can see in the image to the right, which is figure 5-6 from your text, is the pink wavy part that sticks up and kind of creates ridges in the very bottom of the epidermis. So the papillae are there to increase surface area for anchoring. Now, the papillae are also arranged randomly on most of the skin, but they're in rows on things like our palms of our hands and the soles of our feet, and that's there to help create greater ridges so we have better grip. And again, those papillae are important because they form dermal ridges, which are the foundation of our fingerprints. The reticular layer is the deeper of the two layers of our dermis. So it is a deeper layer, and it is supportive and is comprised of dense, irregular connective tissue. And that is really important to help hold things together. There are some elastin fibers that are present here, and those will both stretch out and recoil. Collagen fibers are also present, and what they do is they limit the flexibility. So elastin fibers can stretch out quite a bit, but we need collagen to kind of anchor it down just a little bit more, and so it maintains its integrity. You'll also find glands, hair follicles, and muscle in the reticular layer, and it's a highly vascular site. So keep in mind the epidermis is avascular, whereas the dermis is vascular, and in particular, the deepest layer of the dermis, the reticular layer, is highly vascular. Time for some fun facts about the dermis. So if you look at the poorly drawn sketch on the right, you'll see a person who is very wrinkled and has two different markings on their face that are elliptical around different types of moles. One is on the forehead and one is on the cheek, just inferior to the eye. So you'll see that those are elliptical markings because that's the way that you would resect a mole of any type or even a skin cancer, because we would want to be able to reapproximate those edges to minimize any gaping or scarring. So with an ellipse, we're able to pull that together and create a nice straight line. By contrast, if you were to cut a square or a rectangle, you'd have a really hard time pulling together the corners, even though you might be able to reapproximate the center. So we'll have that elliptical cut, and it's also oriented so that it's parallel to the tension or cleavage lines, which are just the direction in which the majority of the collagen fibers are in that specific area of our body. So if you look at the image below, you'll see that there are tension and cleavage lines throughout our entire bodies. And so those are used for surgeons to be able to determine where exactly they make an incision. Also, there's something called striae, which is just the medical term for stretch marks. And stretch marks are formed by when the dermis stretches out beyond its normal elasticity, and then while it's pulled apart, it heals. And so because it's healed, there's going to be some marks that remain indefinitely, and that's just collagen deposition because it's created a scar. We also have a drug called tretinoin, which you may have heard of, and it's a prescription medication that's being used more and more frequently now, and it's used to basically turn over cells and to also increase blood flow and dermal repair. So you will increase skin elasticity and tautness by using tretinoin. It's not for everyone. There are some risks associated with it. For example, it's definitely a mutagen, so women who are pregnant are contraindicated from ever using it, but it is probably the most effective medication known that can be applied topically to actually truly help repair wrinkles. So recall that the epidermis is avascular, so that means that all the nutrients that come to the epidermis have to diffuse from the deep tissue up to the most superficial aspect. This makes sense, right? We can't have tons and tons of blood vessels in our epidermis, otherwise, if we did, we would just be at risk for bleeding out all the time. So having the epidermis be avascular is a protective effect. So there are two different plexi, or individually plexus, that are found in the dermis. There is the cutaneous plexus and the subpapillary plexus. So the cutaneous plexus is going to border the subcutaneous tissue and the reticular layer of the dermis, and it supplies the adipose tissue of the subcutaneous area and also the tissues of the integument in general. Now the subpapillary plexus is of course beneath the papillary layer, it's subpapillary, and it forms capillary loops which are going to supply the epidermal and the dermal boundary. Contusion is the medical term for a bruise, and really all that happens in a bruise is the dermal blood vessels rupture and the blood leaks into the adjacent tissue. So it takes some time for the tissue surrounding it to basically absorb and metabolize that leaked blood, and that's what happens when your bruise is changing different colors. There's different steps in the progress of that blood and their byproducts being reabsorbed, and eventually it gets cleared out so you don't have a bruise for the rest of your life. You can divide the innervation of the skin into the three different layers of the skin: the epidermis, then the dermal papilla, and the reticular layer of the dermis. So in other words, the epidermis and the two layers of the dermis. So in the deeper epidermis, you're going to find tactile discs, and these tactile discs are there to sense fine touch and pressure. As you move slightly more deep, you'll find in the dermal papilla tactile or Meissner corpuscles, and these are important in sensing light touch. The deepest layer will be reticular, and the reticular layer of the dermis is going to have lamellar or Pacinian corpuscles, and these are sensitive to deep pressure and vibration. Pop quiz question time. The most superficial layer of the dermis is the A. stratum basale, B. papillary layer, C. reticular layer, or D. areolar connective tissue? Well, we know that the dermis has two layers, the papillary and the reticular layer. The papillary layer is the most superficial and the reticular is more deep. So the answer is B. papillary layer. The strength of the skin is due to the blank in the reticular layer of the dermis. Is it A. areolar connective tissue, B. dense regular fibrous connective tissue, C. adipose tissue, or D. dense irregular fibrous connective tissue? Well, we know that areolar tissue is loose, so we can rule that out. Just because it's loose, we know that it's not going to be able to be the primary contributor to the strength of the skin. We can also rule out adipose tissue because adipose tissue is pretty loose and not really going to do a whole lot either. So then we break it down to either B or D, dense regular fibrous connective tissue or dense irregular fibrous connective tissue. Well, in regular fibrous connective tissue, you're going to see the majority of the collagen fibers all lined up in a single direction. So this fits the category of things like ligaments and tendons. So we can rule that out, and we know that it's almost more like plywood in the way that the different fibers of collagen are lined up in dense irregular fibrous connective tissue. And so that is very important for anchoring down our skin and providing the vast majority of strength. So the answer is D, dense irregular fibrous connective tissue. Section 5-3, the subcutaneous layer. The subcutaneous layer, also known as the hypodermis, is the area beneath the skin, so it is not a part of the integumentary system, but we'll discuss it here because it makes sense. So the tissues that comprise the hypodermis or subcutaneous layer are connective tissues. There's loose areolar connective tissue and adipose connective tissue that are present. And the function of this is just to join our skin to the muscle, so we're holding the skin down so it doesn't just flap along wildly. And it also functions as a blood reservoir, which is really important because we can shunt blood either towards the surface or more deep, dependent upon our exposure. Whether we're cold or whether we're warm, we can vasoconstrict or vasodilate, and that blood can be moved very quickly. So about 80% of our adipose tissue is going to be located in this area, in the subcutaneous tissue. And you'll notice in some people, they'll develop more adipose tissue around their abdomen. And if you have a large amount of abdominal fat, that can be classified as central obesity or central adiposity. And in that event, with a lot of adipose tissue around the central area of our bodies, it actually is correlated very highly with a higher risk of cardiovascular disease and cardiovascular events. The hypodermis and the subcutaneous layer is also the location that subcutaneous injections deposit their medication into. So for example, insulin is a subcutaneous injection. Also, a lot of injections for in vitro fertilization are done subcutaneously, just pinched through the skin of the belly. Section 5-4, Skin Color Factors. Two pigments play a role in determining our skin color, both melanin and keratin. Now, keratin has a role to play, but it's minor compared to that of melanin. Melanin is the primary pigment that determines our skin color. And it happens by melanocytes, which are the cells that produce melanin, and they are located in the stratum basale, right at the very bottom of our epidermis. So the melanocytes will produce melanins, and they do this from the amino acid tyrosine. So they'll package that into intracellular vesicles that are called melanosomes, and that will be transferred through the processes or the arm-like extensions of the melanocytes up into the keratinocytes that are nearby, the basal keratinocytes. But it will also continue to pass some of those melanosomes further up into the more superficial layers of the skin. So contingent upon how many melanosomes are present, how far up they get when they persist, and then also the size of them, those will all play a role in determining how dark or light our skin will be. So if the melanosomes are smaller and fewer, then we'll have a lighter, more pale skin tone. Because what happens in this case is those melanosomes are being extended from the melanocyte to keratinocytes in the strata basale and the spinosum. But in darker pigmented individuals, those melanosomes are just a little bit larger and they're more numerous. And so what happens is because there's more of them, the keratinocytes at the basal layers and the lower levels will absorb the melanosomes, but some of them will persist up into higher levels. So as that happens, we have darker skin because the melanin pigment persists. So another neat fact is that the number of melanocytes that we have in our body is the same for the most part, on average, from person to person, if you measure people of all different ethnic groups. So the number of melanocytes has no role whatsoever in determining the darkness of your skin. It's how active those melanosomes are in producing pigment. Here are some clinical correlations that I just love. So the melanosomes, which are containing melanin, are actually going to serve a very neat purpose because that melanin is actually able to sort of shade nuclei from ultraviolet radiation. So they essentially act as little miniature umbrellas so that as the radiation comes superficial to deep into the tissue, when it runs into that melanin, we end up with the tissue underneath not being affected as much by the ultraviolet radiation. So what that means is the nuclei that are subjacent to those melanosomes will not get as exposed to ultraviolet radiation, and therefore that means they will not be damaged. So that means lower risk of cancer. So there is actually some very slight benefit to getting a little bit of sun exposure, but not too much. Now, sun exposure will also cause something called senile lentigos in people who get too much sun exposure. So the bottom image on the left is of a person who has some dark, irregular spots on their face, and they're also known as liver spots, and those are senile lentigos. Also, in genetic cases, we can look at albinism and vitiligo, which are essentially the same thing in that melanin is absent in both of these cases. So the image at the bottom with the hand is showing you a person who is normally pigmented with darker pigment on their fingers, but you'll see on the dorsal surface of their hand, it's much paler. And that's because the melanin is absent and not being not being produced in that area. So that is called vitiligo when the melanin is absent in only specific areas. Whereas if melanin is absent entirely throughout the body, including even in the eyes, that is called albinism. Rosacea is also another clinical correlation. So that's when you can have some considerable redness in the face, and that's affected by blood flow. Beta carotene, if it's too high, can actually cause something called keratinosis. So if you eat far too many carrots, you can actually absorb too much carotene into your skin and develop an orange pigment to your skin. And then lastly, I have a couple of different images on the right. You'll see there's an eye, there's a microscopic image, and then a cross-section of a gross organ. And that is all part of the same type of disease. So this is an example of what's called Wilson's disease, which is a copper metabolism issue. And so copper won't be metabolized properly, and so we end up depositing it in a number of different places. So at the bottom image, what we're looking at is a liver that has a lot of copper deposited in it. And I appreciate that if you're not used to looking at images of gross livers, it might not appear to be very interesting, but you'll notice that it's kind of speckled, and the speckled appearance is what is abnormal. It should be a much more homogeneous, solid color. And if you look at the microscopic image, this is a rhodonine stain, which is probably my favorite stain because I think it looks absolutely stunning. And all of that red and orange speckliness that you see inside of the cells are copper deposited into the cells because it can't metabolize them. And then further, if you see at the very top of the eye, you'll notice that there is a brown ring around the most distal or peripheral part of the iris. And that is, again, copper deposition into the eye itself. Now, another example of a metal deposition disorder would be hemochromatosis, in which iron is abnormally stored in the body and not properly metabolized. And in both cases, both with Wilson's disease and hemochromatosis, this can have long-lasting damaging effects to our cognition and overall health in general. Here are some additional clinical correlations of the skin. So cyanosis is the abnormal coloration of being blue. So cyan is blue, right? And so it results from decreased tissue oxygenation. So if you look at the image of the foot over on the right, you'll see that the toes look sort of purple and dusky. And you can also see that there's some pen marking kind of irregularly on the foot. And that pen is demarcating what areas are dusky and purplish and which areas are still all right. And that is showing you how blood supply being cut off to the foot can result in dead and dying tissues. And that would be a clear case of cyanosis and is a medical emergency because it can result in not only things like gangrene, but also in the requiring of a complete amputation. Jaundice is present, showing you here 2 images below. So there's a newborn, a neonate, who is showing you signs of jaundice, and that his skin is very yellow. And this is caused by hyperbilirubinemia, which if you break it down is hyper, high, bilirubin, emia, blood. So it's high bilirubin in the blood. So this happens frequently with babies that are born prematurely and honestly even times when they're born full term, when their livers just aren't fully mature yet, even though the rest of them might be ready to go. So in that case, that bilirubin can be deposited in a number of places throughout the body and cause long-lasting developmental problems, and it can be deposited into the brain. So if your child is ever born and has hyperbilirubinemia, this will be something that will be tested for extensively to be sure that that level goes down, so that way we know we don't have to put the baby under a light to help them synthesize that bilirubin better. There are also a couple different types of tumors that will develop some skin effects. And so anterior pituitary tumors, such as those that might have melanocyte stimulating hormone, can actually cause some really interesting findings. And Addison's disease is another. So in posterior pituitary hormones, they'll secrete adrenocorticotropic hormone. And both of those are going to have clinical presentations that are similar to melanocyte stimulating hormone. Section 5-5, vitamin D3 production. So one role that the skin plays is in vitamin D production, and this is really neat because typically vitamins are considered essential organic nutrients that are only absorbed from our diet, but vitamin D3 can actually be both synthesized and absorbed through our digestive tract. Pretty cool. So what happens is we get exposed to ultraviolet radiation, and when we're exposed to ultraviolet radiation, it's going to increase a certain steroid in our strata basale and spinosum to produce cholecalciferol, which is vitamin D3. So the liver will convert that to an intermediary product, and then the kidneys will convert it one step further to calcitriol, which is really important in calcium and phosphate absorption. So what this means is if somebody doesn't get enough exposure to sunlight, so they don't produce enough D3 or cholecalciferol, or alternatively, if they're not having enough supplement in their diet, they can develop rickets, which is a D3 deficiency. So the image on the right, which is figure 511 in your text, is showing you clinically what the presentation is of rickets. And you can see that the legs bow out laterally at the knees. And they do this because the bones are actually too weak because there is a deficiency of calcium absorption because of the cholecalciferol deficiency. The clinical note in your text, just before you move into section 5.6, will discuss skin cancer. So let's go through this in a little bit more detail. So there are three primary types of skin cancers. There's basal cell carcinoma, squamous cell carcinoma, and melanoma. And each of these is derived from the name of the cells that have gone haywire, basically, and have uncontrolled cell growth. So in basal cell carcinoma, we have the basal cells, the germinative cells, that have gone haywire. In squamous cell carcinoma, we have, of course, squamous cells that were also involved in this process. And melanoma is particular to the melanocytes. So let's start looking at basal cell carcinoma. So the image that you see on the right is close up looking at a very small basal cell carcinoma. Now these are usually pretty small, slow growing, so we call that indolent when it's slow growing. And they're very common. People have them underneath their eyes frequently, and they have kind of a pearly appearance. So they look like shiny, they look clean, they don't look like they're ulcerated or dark or bloody or anything like that. They're pretty much like just a weird mole for the most part. And so they arise from the stratum basale and also the dermis. Squamous cell carcinoma is going to arise from the stratum spinosum, and it's a really ugly looking skin lesion. If you were to see this on somebody, you would think it's probably a non-healing lesion, like they've cut themselves or burned or something. So it can appear nodular at the perimeter, and you can see in this image on the right that it's kind of erythematous or red around the edges. So we've got an inflammatory reaction going on here. It looks ulcerated and scabbed in the center. And then just before you get to that erythematous border, it's kind of bumpy looking, and that's the nodular surface. So squamous cell carcinoma is pretty invasive, and over time, it can metastasize. So it can also grow and invade in local areas, but metastasize to different parts of the body that are distant. So squamous cell carcinoma is the second most common skin malignancy, with basal cell carcinoma being the first most common. The third type of skin cancer that we'll discuss is melanoma. And you'll see in your text that's referred to as malignant melanoma, and that kind of drives me nuts, and I think it drives a lot of people in medicine nuts, because it's a redundant term. All melanomas are malignant. They are all cancerous. There is no such thing as a benign melanoma. They are all cancer. They can all kill you. So just try to drop the malignant part if you can. But anyway, it's like saying watery water. Like, okay, we get it. So anyway, it's composed of melanocytes. Those are the predominant cell that has gone haywire and has had uncontrolled cell growth. And so these will arise sometimes from previously existing moles or freckles. So you can see the image at the top right is showing you a normal looking mole for the most part if you first looked at it briefly, but then when you look at it a little more closely, you're like, wait a second, it's a little bit irregular. It's lighter at one area and darker at the other. That's the sort of thing that people keep an eye on. If you see that it's changing, that's very important. So we'll discuss the 5 different things to look for in skin malignancies in the next slide. But it's also important to note about melanoma that this can metastasize very rapidly because keep in mind the cell of origin are melanocytes. And where are melanocytes? They're in the stratum basale or the stratum germinativum. So they are right next to the basement membrane. So it's easy for them to break through the basement membrane and then have access to metastasize. Whenever we look at skin lesions to determine whether we think clinically that they might be suspicious for malignancy, we think of the ABCDEs. So first off, what does A stand for? It stands for asymmetry. So you'll see on the left images that are of benign lesions demonstrating the point that's illustrated in the center. And on the right, you see a column of malignant demonstrations of that same thing. So you'll see for A, that if you look to the left, you have a symmetrical looking lesion. It's the same on one side as the other. Whereas when you look at the image on the right, you'll see that the malignant one is totally asymmetric. When you look at B, you're looking at the border. So the border should be even and smooth. So if it's benign, that's great. But on the right, you'll see that the border is not only uneven, but it's hard to define or delineate. So that's definitely suspicious or just malignant. And then we look at color. It should be just generally one color for the most part. But you'll notice the image on the right is showing you, a pinky brown, but then there's also that very dark brown-black area that's suspicious. Then when we talk about diameter, any type of mole that's 6 millimeters in diameter or less is usually considered to be not as risky unless it has other features. Whereas on the right, anything larger than 6 millimeters becomes very suspicious because it's growing beyond what a normal mole would be. Now, 6 millimeters, just if you want to try and estimate in your mind what that is, it's basically about the diameter of a pencil eraser. And then E stands for evolution, meaning that it's changing over time. Normal moles are not going to change over time. They pretty much just sit still and do their thing. But malignancies absolutely will grow. So anything that changes in size, shape, color, or any other trait, let's say it starts bleeding or itching or anything like that, those are all reasons to go in, see a dermatologist, and probably have it removed. This schematic gives you a representation of the 3 different types of cancers found in the skin and how they relate to the subjacent tissues. So on the left, we have squamous cell carcinoma, and you can see that it's mostly superficial. It's in the epidermis primarily, but you will note that there is some of that purple cellular extension into the dermis. So it's broken through the basement membrane of the epidermis into the dermis, which is by definition malignant, no matter what type of lesion it would be. So you'll note that all 3 of these types of cancers are all invading through the basement membrane into subjacent tissue. Now, the basal cell carcinoma is interesting because it's pushing down in a very distinct sort of columnar type pattern. So these are usually more easy to remove. And then melanomas you see on the far right are very deeply invasive because they form right at the basement membrane of the epidermis. So because of that, they're right next to a lot of blood vessels. And if they break through that basement membrane, which it will if it's melanoma, it's got quick access to the bloodstream, which means it has easy access to the highway of running through our body, so it can deposit its cancer cells absolutely anywhere as a micrometastasis and eventually become a full metastatic lesion. Section 5-6, hair. First, we'll discuss some overall hair structure, and then we'll talk about its production and growth and types of hair. So overall, here's our 30,000-foot view. Our hairs, or what we think of them anyways, are actually technically the hair shaft. And the hairs themselves are produced in hair follicles. So if you look at the image on the right, you'll see hair follicles both in cross-section on the image on the left, and then on the image on the right, you'll see that it's intact, showing connective tissue sheathing around the hair root. So we also have erector pili muscles, and you'll see that that is indicated as a diagonal red structure. And it's red, looking like a muscle, which it is. And that structure is going to be able to pull the hair to be able to stand up if we feel cold and we need to shiver to generate heat. We also have root hair plexi of the sensory nerves at the base. And we also have a few other parts. There's the medulla, cortex, and cuticle. And that is if we were to take a hair and do a cross section of the hair itself. So of course, the cuticle is the outer area, and that's what gets totally damaged if you bleach your hair. The cortex is the second most outer layer, and the medulla is the center. So keep in mind whenever we talk about other structures in the body, so for example, when we're talking about the adrenal glands, there are 2 main parts of it, the medulla and the cortex. The cortex is always outer, and the medulla is always more towards the center. Let's discuss hair production from the ground up. So we'll start off with the hair bulb that surrounds the papilla. And then in the papilla, it's composed of connective tissue that has a neurovascular setup in there. So there are both nerves and blood vessels. And the blood vessels are really important because they're going to be bringing in nutrients to the hair so that way it can grow. Now, hair matrix is epithelial, and that is actually the site of building hair itself. So daughter cells are going to grow, and as they grow, they become keratinized. And as they become keratinized, they're going to rise to the top, and then the new growth is going to come along behind them and keep pushing the hair up. So in the same way that skin basically grows from the deepest aspect up to the most superficial, It's the same thing with our hair. So our hair is going to grow about 1/3 of a millimeter a day, which is not really a whole lot, but it does add up over time. And a couple neat fun facts about that is that we can test heavy metals in hair in the actual shaft. So if we were get a trim of your hair, you can determine if at the point when that hair was growing, if there was an abundance of heavy metals like lead, for example, in your bloodstream. Also, you can extract DNA from nucleated cells. So what this means is that DNA is required in order to do any type of medical legal investigation, right? So the hair shaft itself will not have the DNA in it because those are dead cells, right? But if you have the hair root, that will be nucleated and then DNA can be extracted from that. So that means when we administer things like rape kits, we don't just cut hair from people to get a sample of hair to determine what would be their potential hair and what might be the perpetrator's potential hair. We have to actually pull hair physically from the rape victim to be able to be sure that we have known hair roots that we can identify through DNA identification. And a club hair is going to be when a hair is at the end of its growth cycle. So after a certain period of time, and this is different for all people for a lot of different reasons, but once it's done growing, it's eventually just going to stop, fall out, and then a brand new hair will come up behind it. So once it's done its growth cycle, it is called a club hair. So I get to see your smiling faces in your datasheet submissions, and I love your pictures. They are so great. Keep them coming. I can't tell you how much it makes me happy when I see you guys smiling and giving peace signs. Thank you. You make my day. So I thought you might want to see my smiling face in return. And so here, let's talk about some different types of hair. We have vellus hairs, which are what you would consider peach fuzz. So if you look on your face, you'll notice that your face is covered very, very finely with tiny, tiny little hairs, and those are all vellus hairs. They're very thin. We also have terminal hairs, and terminal hairs are what we would use to describe hair in general. So the hair on our head, our eyebrows, our eyelashes, those are all terminal hairs. So they're heavy, they're full of pigment, and they respond to hormonal influences. So for example, hair can change at puberty. Sometimes children who have blonde hair develop darker hair, so the hormonal influence will change that. Pregnancy is also another factor. So again, with hormones, personally, right after I delivered my child Ezra, I had a massive shedding of hair, which was kind of crazy. And then afterwards, all the hair that came back were gray. So you'll see in this image on the right, this was about 2 months into the pandemic with all of the shops being closed, so I couldn't color my hair. And you can see I was going pretty darn gray. So at this point now I've decided I'm embracing it and I'm going gray. Menopause is also another hormonal influence that will affect our hair color as well. So when we have less of our sex hormones circulating, it can trigger the growth of more gray or white hairs. And really, all that white hair is just a lack of pigment. And also there's some air in the shaft that can also affect it as well. But it's just really a lack of pigment overall. Section 5-7, exocrine glands in the skin. In the skin, we have two different main types of exocrine glands, sebaceous glands and sweat glands. So our sebaceous glands are going to be emptying sebum into the hair follicle. So you can see in the image at the bottom, on the left, there is a hair shaft sticking up, and you'll see there's an erector pili muscle that's pulling it at the bottom. And then if you go up just a little bit further where they have that sliced to indicate a cross-section image is going to be shown in the next two images on the right. Just above that plane, you're going to see a sebaceous gland. And so it is going to empty sebum into the follicle, and that sebum serves to help maintain the flexibility and just the general softness of the hair so it doesn't shatter or break. So these sebaceous glands activate at puberty, and up until that point, they're rather inactive. And they release their product via holocrine secretion. So remember, holocrine secretion is when the cell itself basically dissolves. The whole cell in holocrine secretion dissolves in order to release its product. Now, there are also sebaceous follicles, which are different than sebaceous glands. So the glands empty the sebum into the follicles, whereas the sebaceous follicles are not associated with hair follicles at all. They're actually just going to deposit their product directly onto the epithelial surface. Now, you may have heard of vernix caseosa, which is that waxy covering that's present on babies when they're born. And what it does really is waterproof the baby for the most part, because a fetus is going to be surrounded by amniotic fluid in utero for 9 months. And during that time, they can't just soak up all of the amniotic fluid into their skin. The vernix caseosa serves to create a little bit of a boundary for them. So that usually gets wiped away when the baby is first delivered. So you'll see oftentimes the baby's kind of like waxy and white looking immediately after delivery. And that's what it is. It's the vernix caseosa. And another clinical correlation is seborrheic dermatitis, which is called cradle cap when it's present in infants. And what this is like a red and oily scaling of the epithelial surface produced by these sebaceous glands. You're going to hate this. I'm really sorry. I can't do anything to change it. This is the way it is in science. But apocrine sweat glands are actually using the merocrine type of secretion. I can't explain that for you. I'm sorry. But anyway, they will be referred to as apocrine sweat glands in your book, in your exams, and probably in your actual clinical practice. And you will just have to remember that it's technically merocrine, and that's kind of nuts. But anyway, the apocrine sweat glands are those that begin secreting at puberty. And so they contribute to body odor, right? Because, little 5-year-olds and 6-year-olds don't have BO, but as we become teenagers, we all suddenly start to need deodorant, right? And so these empty their product into the hair follicle. And again, they use the merocrine type of secretion, which I've included here in red just because I really want to make sure that you get that point. There are also eccrine sweat glands, and these secrete something different. So they secrete just mostly water and just some waste from the glands. So they're really innocuous for the most part. They empty their product directly onto the skin surface, and this is what creates sensible perspiration, meaning sweat that you can feel. So you go to the gym, you get sweaty, it is your eccrine sweat glands that are producing that sweat. And it also has a very important role in thermal regulation to help us cool down. There are 2 other type of skin glands that are present, but we'll just discuss them briefly. So the first is mammary glands, and these are the glands that are responsible for lactation or for producing milk. So these secrete their product via the apocrine method. There are also ceruminous glands, which is indicated by the image to the right, which I apologize for. I realize this is disgusting, but what you see there is cerumen or earwax, and that is formed by combining secretions from the ceruminous glands with contents from the sebaceous glands together. So it's a combined product, but together we'll just call it cerumen or earwax. Section 5-8, nails. Nails grow in much the same way that hair or epithelium does, from the deep aspect up to the superficial aspect. So if you look at the image on the right, you're going to see a couple different images of a fingernail. And so you can see the nail body is the part of the nail that you actually look at and see on your finger or your toes. It's the visible portion that's on the nail bed. The nail bed is the soft tissue beneath the entire nail to which the nail is firmly adhered. The part, by the way, that is not firmly adhered, so for example, if you want to clean underneath your fingernails, you'd be cleaning under the hyponychium, or hypo, below the nail. But technically what is below the entire nail is the nail bed. So now if you look at the image at the top right, you're going to see a cross section of a nail showing you also the phalanx or the bone of the fingertip as well. So the nail body is up on top, and then there is both a groove and a fold at the side. So the groove is the part at the very edge of the nail, and then where the skin kind of comes up a bit, we have a lateral nail fold as well. And then when you look at that image at the top left, you're going to see at the very base of the nail, at the more inferior aspect of the nail, there is a whitish half moon area called the lunula. And what's happening there is that we have obscured the blood vessels that are underneath in the nail bed, and so we can't see it, so it comes across as kind of white. But the blood vessels underneath our nail bed are what creates the pinkish look of our nails. So back to the hyponychium for a second. So when we clean out underneath our nails, we're cleaning out the hyponychium, and what's sticking out to look like long nails, if you will, is considered the free edge. So the nail starts growing at the nail root down at the bottom, and it emerges from the cuticle, which is known as the eponychium. There are a whole bunch of conditions actually that affect the way nails grow, and it can range from clubbing or pitting. All sorts of different things will happen. So when you see these things in somebody's nails, think of it as a hint to look into what that might clinically correlate with. It's not always a slam dunk, but it can definitely be a tip off for something that needs to be investigated more thoroughly. So, for example, psoriasis is something that will present clinically as having pits in the nails, and that happens because you have an extremely rapid mitotic rate or cell turnover in the stratum basale. Section 5-9, Integument repair. Overall, this is a review, but we're going to get into a little bit more detail in the subsequent slides. So when we discuss tissue repair, tissue can repair in one of two different ways, either through regeneration or through replacement. And in regeneration, what's happening is the same type of tissue that was there before regenerates and it comes back and looks normal, so you have no scarring at all. It's regenerated. But on the other hand, sometimes the damage is too extensive to have it return to its normal appearance and function, in which case we get the development of a scar. And a scar is really just collagen laydown or connective tissue that replaces the epithelial tissue that was there before. So if you look at any scar that you have on, your knee from when you fell when you were a child, you'll notice that it's actually a firmer tissue than the surrounding tissue is, and that's because of the collagen deposition. Keloids are a type of lesion that you see on skin that is formed by excessive scar tissue. So when that collagen is laying down to heal up an area, you have an excess of that collagen deposition, and that results in a big looking scar. Now, there can be two different types of healing for wounds. Wounds can heal either by primary intention or secondary intention. Primary intention is simply when you are able to reapproximate the two edges of a cut area. So, for example, you cut your foot, you get stitches, they're going to pull the two edges together and suture them together so that way the two edges are touching, and that will be healing by primary intention. Now, on the other hand, let's say you have a big burn on your hand, and so there's a wide swath of tissue that can't be pulled together. It just has to heal as it is. That's going to heal by what's called secondary intention, and so you will most likely end up with a serious scar for secondary intention damage if it's severe, whereas even for a full thickness cut, a primary intention healing that comes together properly, that can actually have a very, very small scar as compared to the secondary intention healing. We discussed this in a previous lecture, but there are 5 cardinal signs of inflammation. You might sometimes see this in your text as actually being 4 cardinal signs of inflammation, because the last one is that all 4 of those signs result in a disturbance of function. So that could be considered the 5th sign if they're asking you for 5 signs. So the 4 signs would be redness, heat, swelling, and pain. Redness is called rubor in Latin. Heat is calor, like calorie. A calorie is a unit of energy and heat. Swelling is tumor, and pain is dolor. So the redness is going to be formed because of increased blood flow to the area. And then heat is going to be generated because of that increased blood flow to the area and some pyrogenic chemicals as well. And then the swelling is going to occur because we have increased permeability of the vessels in the area, and that allows white blood cells, macrophages, and the immune response in general to address whatever the insult is. And then as a result, because we have this increased blood flow and we have this increased permeability and more fluid and swelling and heat, all of this is going to trigger our nerve endings in the area and create pain. And then again, finally, it results in a disturbance of function. So let's take a look at wound healing in the 4 stages that are outlined in your text. So figure 516 shows you the next 4 slides, and we can go through these one by one. So in the first step, we have the inflammation stage. So you can see at the image on the right, we have a cut. And in that cut or incision, you can see that there is bleeding that bleeds into the cavern, creating almost like a river running through a valley of blood. And so when that bleeding occurs, there are going to be mast cells in the area, and they're going to secrete chemicals that are going to trigger inflammatory response to bring other things to that area to help clean it up. So in the migration phase, we've already had blood pool into the incision, and blood has formed a scab over the very top of the blood, so it's dry, it's no longer leaking fluid any longer. At this point, because we've had those mast cells recruit other different types of cells to the area, one of those types of cells are phagocytic cells, and they will eat up debris, they'll eat up any old dead dying cells, and so they are recruited to the area to come and try to clean things up. You'll also see some clotting around the edges of the area, and that's going to isolate it from any further bleeding into the surrounding tissue. About a week later, we're looking at the proliferation phase. So now it's not so much the cleanup crew coming in trying to eat up old debris and bacteria, but rather we're rebuilding after the demolition. So what's happening now is we have epidermal cells that migrate in to start creating new epithelium. We have that collagen fiber meshwork that's been produced that's in the area to act as scaffolding. And the phagocytic activity is almost ended, but it's not completely done yet. Finally, we have the fourth phase, which is the scarring phase. So at this point, it looks like everything is sealed up and clean on the epithelial surface. The scab has been shed, so it looks healed. However, at this point, there will be a slight shallow depression where that injury was. And what's happening underneath that is fibroblasts are still creating more collagen. So more scar tissue will develop, and that will eventually rise it up so it becomes to be at least at the same level as the surrounding tissue and potentially even higher. This image shows you how wounds heal by primary intention and secondary intention, which I discussed previously, but it also includes tertiary intention, which is a little different. So just to recap, primary intention is usually a clean incision, so for example, a surgical incision, and that can be reapproximated, so the two sides get pulled back together, it gets sutured together nice and tight in a smooth line, and then you can see at the top right, you only have a slight hairline scar after that's healed. Then contrast that with secondary intention, in which case you have a big gaping wound, right? So it can't be pulled together, so it just has to heal in situ as it is. So granulation tissue will form in that wound and build up, and eventually the epithelium will grow over it, but you end up with a bizarre looking scar. And then in tertiary intention, you have a wound, and it can have granulation tissue that starts backfilling in where that wound was, but the granulation tissue is growing kind of at an advanced rate. There's a little bit more of it. And if you try to suture that together, you're putting together granulation tissue and it's going to remain. So you're going to have a bigger scar in tertiary intention as well. Burns are categorized as first, second, or third degree, contingent upon what level of the skin and subcutaneous tissues have been involved. So the image on the right will show you each of the three as it appears clinically, as well as in a schematic showing you the cross section. So in first degree burns, you have things like sunburns that are not terribly bad for the most part. In this case, only the epidermis is affected. So first degree, only the first level, only the epidermis. So as a result, it might get red, it might be painful, it might be inflamed, but there's no scarring. In second degree burns, we're involving both the epidermis and the dermis. So 2 degrees, 2 levels. So at this point, you can see in the image on the right, you have some blistering that's forming, and scarring can definitely occur at this point. Third degree burns are incredibly nasty because they are all the way through 3 layers. When they say 3 layers, what we mean is the epidermis, the dermis, and deeper, whatever that is, whether it's muscle or fat or whatever is beneath it, it's a third degree burn. So in this case, it is full thickness through the entire surface of our skin. And of course there will be scarring because it has to replace as much as possible, but it's going to be definitely very different looking than before. During a third degree burn, you also have the risk for heavy fluid loss and infection. Anytime you have broken down the border of our skin, we have a risk for infection because there are microorganisms everywhere just waiting to jump in. And third degree burns are actually not going to be as painful. Now, that's not to say there won't be any pain, but they will be less painful because this burning burns through nerve. So you don't have the sense of pain because those nerves are fried because they're burned. When a patient has been involved in a burn, and particularly a bad one, for example, in a fire, we try to estimate what amount of surface area has been involved in the burn. So the schematic that you see here below is clinical note 5-9, and it's showing you the difference between either an adult or a child in the way that we estimate the amount of surface area that's been involved. So we have something called the rule of nines, and basically we divide different parts of the body, of the adult body anyway, into nines. So the head is 9%, each upper limb is 9%, the trunk, front and back is 36%, which is how many sets of 9. We also have the genitalia, which is only 1%. It's just a tiny little, we add that on, right? And then, because if you think about it, 9 sets of 9 is 99%, so we need to add the 1 in there somewhere, so that's where it is. And then the remaining 18% are the 2 lower limbs. So each limb is 18%, or sorry, is 9% each. A child is broken down a little bit differently, but the rule of nines will get you through most adult estimations. Lastly, we have aging skin, section 5-10. Aging skin. Well, this is the bad news bears slide of the whole entire presentation. Basically, everything falls apart, okay? So the epidermis and our dermis thins in time, and so that can create all sorts of risks. So if our dermis thins, we're more prone to injury, and if we're more prone to injury, then that can create a passageway for microorganisms to gain access to subcutaneous tissues and therefore infection. We also have dendritic cells decrease by 50% from what the values were when we were at age 21. So when those decrease, that's going to reduce our ability to respond via our immune system to foreign invasion of microorganisms as well as to skin cancers. We also decrease our vitamin D3 production by about 75%. So supplementing your diet with vitamin D3 is very important, in addition to also getting a little bit of sunlight. Our melanocyte activity declines, so that means we produce less melanin, and therefore our skin will not have that protective additional layer against ultraviolet radiation. Our elasticity, glandular, and hair follicle activity all declines as well. Our blood supply to the dermis declines, which is interesting because you'll note that a lot of elderly people will also feel chilly pretty frequently, and they'll want a blanket or a cardigan to keep them warm. And that's not in their head. That is absolutely a biological phenomenon of blood being distributed more towards the internal organs rather than to the distal dermis. So having less blood in the dermis means you have a cooler feeling skin than what, say, we might being younger. We also have a loss of collagen, hence everything gets wrinkly and saggy. And we have decreased sex hormones because when we go through menopause or when men go through andropause, we have decreased sex hormone levels. And so that affects all of our secondary sex characteristics. So that means we have decreased hair and decreased body fat. And finally, our skin repairs more slowly. So like I said, overall, everything falls apart and the wheels start coming off.
Thank you so much for staying with me until the end of this lecture. I hope you're really liking it, and I think that you probably are liking this chapter better than what we've studied so far because it starts to feel really clinically relevant. So as the course progresses, it will feel more and more this way, and you'll have a lot more appreciation, I think, for what you're studying, and it just gets to be a lot of fun. So anyway, if you have any questions, please email me, and we can always set up a time to Zoom. Have a great week, everybody.
I used a lot of different references for this lecture today because I wanted to show you some really great photos. So I've referenced them all here so you can take a look if you're interested.